So today's topic is on Down syndrome. Okay, so Down syndrome. So as the name suggests that it is named after the person who has been identified the disease. Okay, so inside this, what we are going to see is we have to see what is a Down syndrome and how it has been identified in the history, and what is the cytogenetics that results in the Down syndrome, and what are the clinical features, what are the associated abnormalities, how will you manage this case, what is the prognosis of this child, and how will you prenatally diagnose and counsel the parents. Okay, so in an overview, most common chromosomal disorder that is compatible for survival, that is Down syndrome. So actually நம்ம ஏன் நிறைய Down syndrome case பார்க்குறோம்னா, because this Down syndrome is one of the most common chromosomal disorder that is compatible with survival. So remaining வரது எல்லாமே வந்து will go for miscarriage. Majority of your chromosomal abnormalities will end up in miscarriage. So அதனால நமக்கு clear cut the most common chromosomal disorder that is prevalent in the community என்றது நம்மளால கண்டுபிடிக்க முடியாது. But since we have been seeing this more, okay, because they are surviving and so compatible for survival இருக்கிறதுனால தான் we are seeing this as more. So this is the most common chromosomal disorder that is compatible for survival, and it is named after the physician, that is Langdon Down. In 1866 he described the phenotypic features of the Down syndrome. Okay, and at that period he also knows the main problem why these children are like this, but he described a group of children who are presenting with the similar phenotypes. That's why we have given the credit to the person Down, and it is described as a mongoloid child of European parentage. So actually this first time has been identified in the Europe, so where they see that the facial features of these children will be similar to like a Mongol. So that's why they have given this name as a mongoloid faces. But since it has been criticized that we are criticizing a race and all the other things, discrimination has been there, the issues has been arising because of that. So nowadays we are not preferring to use this mongoloid faces, we are preferring to use a Down's faces. Okay, so example you சொல்லும் போது mongoloid faces அந்த மாதிரிலாம் சொல்லாதீங்க. So you just kill it as Down's faces. Okay, in 1959 only, after this 90 years, then only another doctor John June who discovered that it is primarily because of an inheritance of the extra chromosome 21. So that is the extra chromosome 21 is the one that results in Down syndrome. So that's why we initially call this as trisomy 21. So the frequency is, that is in an average the frequency is 1 is to 1000 newborns. In Asian countries அதோட incidence வந்து கொஞ்சம் கம்மி தான், whereas in case of foreign countries the incidence is high. Predominantly affects males with the ratio of 1.3 is to 1. We know that it is due to the extra chromosome 21, and this extra chromosome comes from majority of the side, it comes from the maternal side. Even though 5% is contributed by father, 95% comes from the mother. And as the mother's age increases, the risk increases. So in this you will see that in a younger age group between 15 to 29 years, the risk is 1 in 1550. Whereas as the age increases, it increases. After 35 years, the risk is almost very high. After 45 years, the risk is 1 in 50. It is primarily attributed to the long exposure of the oocyte to the environment. This I have already told you. As and when a baby which has been destined to be a girl child, the 300 oocytes, the millions of oocytes that has been present in the fetal life will be ultimately going in for competence, and only 300 oocytes are selected for this girl child to be released in a reproductive age group. So this 300 oocytes will be suspended in a phase of prophase from the period the child has been born. Okay, So this suspended prophase period la ரொம்ப நாள் இருக்கு. So as and when the child after attaining menarche, as the child's reproductive age advances, then the oocyte which is competent enough will be released, and those oocytes which has been there inside the body is exposed to more toxins. So because of this long exposure of this oocyte to the environment, the incidence is more as the mother's age increases. And coming to cytogenetics, we have three mechanisms by which we can have Down syndrome. One is because of an extra chromosome itself, that is trisomy 21. It contributes about 90%, and that is the most common. And translocation is seen in about 4%, where the 21st chromosome is translocated with another chromosome. Okay, then 1% occurs in mosaicism. So you see that in 21 chromosome, the extra cell has an extra chromosome. Each cell has an extra 21 chromosome, and this most commonly comes through the meiotic non-disjunction. Okay, meiotic non-disjunction. So that's the 21 trisomy 21 cause. Most often this occurs on the mother side. So the most common will be maternal meiotic non-disjunction. So this I have already explained. The risk increases as advancing maternal age. I don't know whether it will play. I'll tell you. So audio கேக்குதான்னு மட்டும் பாருங்க. Excuse me, 1 minute. ஆனா பேசுறது கேக்குதாமா?
எஸ் சார் கேக்குது சார்.
Excuse me, wait. Sorry, 1 minute. Okay. So this is non-disjunction in meiosis 1. Okay, as you see that in the first meiosis step itself, that's a non-disjunction that results in cells having an extra 21 chromosome and two cells will be having no 21 chromosome. So this occurs in meiosis non-disjunction in first segment. So this is meiotic non-disjunction in second phase. So second phaseல பாத்தீங்கன்னா உங்களுக்கு ஒன்னு மட்டும் தான் அப்நார்மலா இருக்கும், ஒரு ட்ரைசோமி ஒரு மோனோசோமி, மித்த ரெண்டுமே நார்மலா இருக்கும். Okay, so that is you want to understand that meiotic non-disjunction at any stage, whether it is in first meiotic division or in the second meiotic division, can result in trisomy 21, and this meiotic non-disjunction occurs at the anaphase stage as the chromosomes are pulled into the cells. Okay, Okay, so this is about this trisomy 21. Now, the other second important mechanism is translocation. As we all know that the chromosomes can exchange their place. So this you call this as translocation. And this will be balanced if the exchanged chromosomes are there. Like for example, ஒரு 14ல இருந்து ஒரு லாங் ஆர்மோ 21ல இருக்கிற லாங் ஆர்மோ ரெண்டு ஒண்ணுத்துக்கு ஒண்ணு இடம் மாறிக்கிச்சுன்னா அதை வந்து நம்ம வந்து என்ன சொல்றோம் பேலன்ஸ்டு டிரான்ஸ்லோகேஷன் அப்படின்னு நம்ம சொல்றோம். Okay, so here part of a 21 chromosome translocates to another chromosome. It is 50% random and 50% inherited. Okay, so this translocation will be there, and 50% it is random, and 50% it can come as an inherited. Like already parent on the translocated chromosome. So parents usually has a balanced translocation. So most of the time these parents will be phenotypically normal. Okay, they are having a balanced chromosome. Whereas when they transmit it into the child, okay, which results in an extra 21 chromosome, then definitely when there is an unbalance in that, and they will have the Down syndrome. The chromosome 21 commonly translocates to two different types of chromosome. On karyotyping, based on the length of the chromosomes, long arm short arm ratio which you classify the chromosomes into A, B, C, D, E, F, G. So in the mari number 7 segments are pirikirom, of which 13, 14, 15 comes under D group, and 21 and 22 comes under G group. Okay, so translocation can occur between a D group chromosome or a G group chromosome. Okay, so that means 1321 or 1421 or 1521. Of these, 1421 is most common. Okay, sometimes the translocation can occur between the GG chromosomes itself. Like 21 ko 22 ko idaiya kuda translocations nadakum. So you call this as 21, 22, and even 21 chromosomes itself can get translocated. So they call us 21, 21 translocation. So these are the possible combinations you will expect. T1321 or 1421 or 1521 and 2121 and 2122. So of these, 1421 is the most common cause. So when you see that the translocation carrier, okay, so the father or mother or translocation carrier irukanga, ipo will get a chromosome from both the father and the mother. Okay, so இப்படி எடுக்கும்போது if a father which has a translocated carrier of 13 14, sorry, we'll take it as downs னு எடுத்துக்குவோம், ஒரு 14 21 chromosome carrier இருக்கு. ஸோ அதுல வந்து 14 குரோமோசோமும் இருக்கு, 21 குரோமோசோமும் இருக்கு. ஓகேவா? ஸோ இப்போ அதுக்கடுத்து அம்மா கிட்ட இருந்து you will also receives one copy. ஓகே, ஸோ இது தனித்தனியா பிரிஞ்சு இது ரெண்டு செக்ரிகேட் ஆகும்போது what happens ultimately, the presence of extra chromosome 21, okay, the presence of extra chromosome 21 in one of the parent will be added up. So அப்போ already இருக்கிற ரெண்டு 21 chromosome ஓட he will also has another chromosome, that is trisomy. Okay, so then we'll go into mosaicism. Mosaicism means there is a random mitotic error at the embryonic stage. So embryonic stage liye cell divide ஆகும்போது randomly ஒரு செல்லுல வந்து 21 chromosome extra வந்து divide ஆகுது. Here it is a mitotic error, not a meiotic error. So you will have two sets of cells. So one set will have a normal chromosome and one set will have a trisomy 21. Since these children will not have a complete pattern, so எல்லா செல்லுமே 21 இல்லாத 21 trisomy இல்லாததனால phenotypically அவங்க வந்து diagnose பண்றது ரொம்ப கஷ்டமா இருக்கும். So that leads to diagnostic dilemma also. So for this we have to go for karyotyping. So going into the clinical features, on clinical features we will segregate into newborn la enna pattern இருக்கும், then கொஞ்சம் பெரிய சைல்டு வந்து என்ன பேட்டர்ன் இருக்குன்னு பார்க்கணும். நியூபார்ன்ல நம்ம டவுன் சிண்ட்ரோம் கண்டுபிடிக்கிறதுக்கு we have a special criteria called as Hall's criteria. ஓகே, ஸோ மொத்தம் 10 criteria இருக்கு. அந்த 10 criteria-ல more than or equal to 4 இருந்துச்சுன்னா the possibility of Down syndrome is very very high. Okay, so you categorize them into general and faces, then hands and pelvis. So இது நாலுத்துக்குள்ள தான் categorize பண்றோம். General, presence of hypotonia, hyperflexibility of joints, poor morose reflex, இதெல்லாம் ஜெனரல் வருது. Then flat faces, slanted eyes, abnormal ears, then excess skin on the posterior surface of the neck. On the hands, the simian crease, presence of simian crease and hypoplasia of the middle phalanx of the fifth finger, we call it as clinodactyly, and dysplasia of the pelvis. Okay, so இதுல ஏதாச்சும் 4 இருந்துச்சுனாலும் we have to investigate the child for Down syndrome. Okay, in older children, கொஞ்சம் பெரிய சைல்டுக்கு see Down syndrome case எல்லாமே நீங்க head to foot examination தான் கான்சென்ட்ரேட் பண்ணணும். That's why I described all these things on head to foot examination. In general, the child will have a short stature because growth retardation is a rule for majority of the chromosomal disorders. Then there will be hyperflexibility of the joints. In the face, you see the head size is small and you see that the face is flat and occiput is flat. It means face வந்து frontலயும் backலயும் compress ஆன மாதிரி இருக்கும். So there will be a flat faces will be there, flat facial profile will be there, and in the occiput also it will be somewhat flat. These type of head structure is called as brachycephaly, and this child will also has a delayed closure of anterior fontanelle and posterior fontanelle. This can be secondary to hypothyroidism, which is more common in these children too. Eyes will have a mongoloid slant. Normally the lateral canthus will be at a higher level when compared to the medial canthus, but in these children it is exaggerated. Okay, the lateral canthus normally இருக்கிறத விட இன்னும் higher up-ஆவே இருக்கும். So this is what is called as mongoloid slant. Then the presence of epicanthal folds. These children will have a tissue that can be present in the medial end. Mostly medial side la தான் epicanthal folds இருக்கும். Then in the iris you can able to see some white spots. So this is what is called as speckled iris, otherwise known as brush field spots. And in the lens they can have a lenticular cataract, and in fundus they will have a spoke wheel pattern, you call it as spoke wheel fundus. Ear, the ear size may be abnormal or the position may be abnormal. Size, it could be either absent or it could be small or it could be malformed. So மூணுத்துல எப்படி வேணாலும் இருக்கலாம். Because of this malformation in the ear, conductive deafness is so common in Down syndrome because external auditory meatus வந்து ப்ராப்பரா இருக்காது, வேக்ஸ் கண்டினியூஸா கிளியர் பண்ண முடியாது. So because of this wax obstruction in the abnormally shaped external auditory meatus, இதனால conductive deafness is so common in Down syndrome. Then low set ears. Low set ears means, so when you draw a line, okay, from the outer canthus. You have to see 1/3 of the ear must be above this line. And the mari illa abdina, you call this as low set ears. Then in the nose, there may be depressed nasal bridge. Okay, so because it is the nose, nasal bone is not properly formed, and they will have a small nose. Then in the mouth is relatively small, so they will have an open mouth. They are unable to put the tongue inside, so the tongue is constantly exposed out. So this exposed tongue gives an appearance of a macroglosia, but it is not true. It is not true macroglosia. Relatively small mouth irukkaradunala tongue is protruded out, and this protruded tongue is exposed to the atmosphere. So the epithelium now becomes keratinized, and this keratinized causes a rough surface in the tongue. This you can able to see. You can also see some furrows also. So that's why these tongue, which is similar to scrotal rugosity mari irukum. So adanal இந்த tongue-க்கு பேரு scrotal tongue அப்படினு ஒரு பேர் இருக்கு. Okay, apart from this, dental dysplasia can be there, and palate may be higher. In the neck, it is short and webbed neck. You can able to see the redundant folds over the back of the neck. So this gives you another important significance, that presence of a nuchal translucency we can see in the antenatal diagnosis. So on the mari, this also gives you a clue. So this you can see the down faces. You see that the nasal bridge is flattened. You can see the presence of epicanthal folds are ridge. Okay, epicanthal folds is there, and you can able to see some white spots. This is brushfield spots. Okay, so this is a typical Down's faces. You see that how the child is happily smiling, and you can able to see that the flat profile of the occiput. This is a normal profile. Normala head vandu ipdi da irukum. Here you can able to see that it is flat, and nose ume pathina it will be somewhat more flat. Okay, where here the nose is somewhat protruded. So when நீங்க மேல இருந்து கீழ வரைக்கும் பாக்குறீங்கன்னா நம்மளோட ஃபேஸ்ல வந்து ஒரு லாங் சைஸ் ஸ்கேல் வெச்சோம்னா நம்மளோட ஃபேஸ்ல அந்த மாதிரி வைக்க முடியாது. whereas down syndrome இருக்கிற குழந்தைகளுக்கு mostly you can able to place a flat scale. Okay, so the head is compressed both posteriorly and anteriorly. This results in brachycephaly. So you can able to see this tongue is constantly exposed and results in keratinization and furrowing. This you call this as scrotal tongue. Then going into the other features, in the hands, the fingers itself is so small. Okay, so I'm about to end time. So clinical features mudicha odana I'll cut it and I'll again rejoin. Okay, so hands பொறுத்த வரைக்கும் பாத்தீங்கன்னா the hands are small, fingers are small, so that's why you call this as brachydactyly. brachy அப்படினால சின்னதா இருக்குன்னு அர்த்தம். So brachydactyly. Then you can have a simian crease, a single transverse palmar crease. This is called as simian crease. And an incurving of the little finger. Okay, an incurving of the little finger secondary to the hypoplasia of the middle phalanx results in incurving. So on the incurving of the little finger ku peru da clinodactyly. Okay, in the foot what you are supposed to see, you will able to see a crease that has been descending down from the first and the second intertoe space. So this is called as sandex crease, and அதே ஏரியால கொஞ்சம் எக்ஸ்ட்ரா கேப் இருக்கும், அதை நம்ம சாண்டல் கேப் அப்படின்னு சொல்றோம். ஸோ சாண்டல் கேப் அண்ட் சாண்டெக்ஸ் கிரீஸ் இதெல்லாம் நம்ம ஃபீட்ல பாக்குறோம். இந்த ஸ்பைன் அண்ட் பெல்விஸ்ல பார்க்கும்போது தி ஸ்பைன்ல லிகமெண்ட் லாக்ஸிட்டி இஸ் சோ காமன். ஸோ அது ரொம்ப காமனா பார்க்கறது வந்து அட்லாண்டியோ ஆக்சியல் இன்ஸ்டபிலிட்டி. ஸோ இந்த C1 and C2 ஸ்பைனுக்கு the important ligament, you have a ligament, transverse ligament that keeps the C2 in place. Yeah, so sometimes it lax irukradunala the atlantic axial instability can result in problems, and the pelvis will be dysplastic, it will be somewhat widened. So this widened pelvis results in a shallow acetabular angle. So acetabular angle shallow ஆயிடுறதுனால the hip femur oda head வந்து ஒழுங்கா போய் பொசிஷன் ஆகாது. சோ இதனால congenital developmental dysplasia of hip வந்து ரொம்ப காமன். Dermatoglyphics ulnar loops in all fingers. So எல்லா ஃபிங்கர்லயுமே நீங்க அந்த ஃபிங்கர் பிரிண்ட் பேட்டர்ன்லாம் நீங்க படிச்சிருப்பீங்க இல்லையா? So you have loops, folds, so அதெல்லாம் இருக்கும். அதுல dermatoglyphicsல they will have ulnar loops, predominantly எல்லாத்துலயும் ulnar loops இருக்கும். Then they'll be having distally placed axial triradii. Okay, everybody when you see it here in the wrist, okay, the wrist, you can able to see triradius. A triradius is nothing but ஒரு மூணு லெவல்ல மூணு பேட்டர்ன் இருக்கும். ஸோ ஒரு ஏரியால இப்போ மோஸ்ட்லி பார்த்தீங்கன்னா இந்த ஃபிங்கரோட பேஸ்ல எல்லாம் உங்களுக்கு அது நல்லாவே தெரியும். ஓகே, டீச்சர் ஃபிங்கரோட பேஸ்ல உங்களுக்கு நல்லாவே தெரியும். ஸோ யூ வில் ஹாவ் ஒரு மூணு ஏரியாவோட கான்ஃப்ளூயன்ஸ் மாதிரி you can able to see a small triangle. Okay, so you can able to see a small triangle. I don't know how far it is very reliable to you. So you will able to see every base, எல்லா பேஸ்லயுமே வந்து எல்லா ஃபிங்கரோட பேஸ்லயுமே உங்களுக்கு வந்து ஒரு triangle தெரியும். Okay, this is what is called as triradius, and you can also see a triradius in the base of your palm. Okay, so you in the base of the index finger, base of the little finger, and at the base of the hand, இது மூணுத்தையும் ஜாயின் பண்ணீங்கன்னா you will have a triangle. Okay, and this is what is called as axial triradius, and this axial triradius that is been displaced or down accordingly. Okay, this results in this triangle to be obtuse rather than acute. Okay, in lower limb you can able to see the tibial arch or small loop or distal phalanx. See, you can able to see the incurving. Sometimes the middle phalanx is hypoplasia of the middle phalanx. Okay, so this is what is called as clinodactyly. You can able to see the fingers are short. Okay, so the fingers are short, the hand is relatively short. So this is brachydactyly, this is clinodactyly, and the presence of transverse single transverse palmar is called as semi-increase.
Hello, sir.
Okay, moving on to the genitalia.
Hello.
You have micropenis. Okay, the
Hello,
sexual
sir.
underdevelopment is a rule. So micropenis, orgasm, and sterility. Remember, all males with Down syndrome are sterile, not females. Okay, females with Down syndrome can be able to produce an offspring. Okay, in skin there will be hyperkeratosis and there will be alopecia areata, and CBS,
Hello,
congenital
sir.
heart disease, will be there. Okay, it is not seen in all children, but it's there in most of the children. So the most common defects in the order is endocardial cushion defects. That's the most common.
Hello, sir.
VSD,
Sir. Hello,
the
sir.
most common in Down syndrome is endocardial cushion defects. In DAT,
Hello.
generally abdomen disorder, and divergence it will be disturbed. Okay. See, you will able to see this saddle gap. So you have a gap between the first and the second toe. This is called the saddle gap. And in CNS, so you will have mental retardation, which will be somewhat low. The mental retardation may be abnormal. Okay, mental retardation may be. Hello. Soluma. ஓ சரி சரி சரி, அப்ப நான் கட் பண்ணிட்டு வரேன் அப்போ.